Watch this video to learn how to detect and address synovitis in hemophilia and apply this knowledge into clinical practice. Hello, my name is Carmen Escuriola and I welcome you to this video where we are going to focus on synovitis in hemophilia, why it matters, how to recognize it early, and why we should actively look for it even when patients are not reporting symptoms. Haemophilia A is a genetic bleeding disorder which is caused by deficient or absent factor VIII that results in an increased bleeding tendency. It is characterized by spontaneous and recurrent joint bleeding, also called hemarthrosis. But it can occur even in patients receiving prophylaxis, usually after trauma or during physical activity. Joint bleeding can affect over 30% of children and up to 60% adults with severe hemophilia A. Bleeding into the synovium can exceed the synovial capacity to remove blood. During a joint bleed, hemoglobin releases iron, which is stored in the synovium as hemosiderin. It triggers synovial inflammation and angiogenesis. The inflamed synovium becomes highly vascularized and fragile, therefore predisposing the joint to further bleeding and propagate a cycle. Hemophilic synovitis occurs due to a double hit mechanism: a chemical hit from iron-driven cartilage damage and a secondary inflammatory hit from cytokines that propagate inflammatory damage. Over time, this damages cartilage and subchondral bone, leading to hemophilic arthropathy. Even one bleed or subclinical bleed can lead to hemosiderin deposits and initiate this process. Synovitis therefore represents a critical window to act before irreversible joint damage occurs. While the lives of people with hemophilia have been improved thanks to the development of therapeutic agents and prophylaxis, helping to maintain healthier joints and therefore decreasing bleeds and pain, synovitis can still occur even in patients who appear well controlled and report neither bleeds nor symptoms. There are a number of well-known signs and symptoms identifying joint bleeds even at an early stage, such as sensation of fullness, stiffness, pain, or tingling in the joint. But subclinical bleeds can occur without any clinical signs. Bleeding is intrinsic to hemophilia, so hemophilic synovitis may not cause obvious symptoms like pain and swelling that are common in synovitis in people without hemophilia. However, subclinical bleeds contribute to inflammation, synovitis, and long-term structural damage. Synovitis is a critical window for early intervention before developing long-term damage. It is the last reversible stage in the cascade leading to arthropathy. Therefore, joint monitoring should be proactive rather than symptom-driven. Studies using MRI and ultrasound have shown synovial hypertrophy and hemosiderin deposits in joints without reported bleed history. Because synovitis may be clinically silent, physical examination assessment tools such as the Hemophilia Joint Health Score are not sensitive enough to detect these early changes. Therefore, imaging plays a critical role in detecting synovitis early. MRI is the gold standard for imaging of the synovium and hemosiderin deposits, but access is limited because of availability, practicability, and costs. In clinical practice, ultrasound is a practical and accessible way to detect subclinical synovial hypertrophy and monitor joint health over time in clinical routine. Ultrasound provides instant information on the status of a joint to detect problems that may have been missed during physical examinations. Standardized ultrasound protocols such as HEAD-US allow the structured assessment of joints that are most commonly affected by hemophilia, providing reproducible and comparable information to define patients' joint status. Ultrasound offers suitability for multi-joint screening. Guidelines for the management of hemophilia suggest musculoskeletal ultrasound for the clinical assessment and management of hemophilic arthropathy. It is also considered useful to detect silent synovitis in children with no clinical signs, including those patients who do not report breakthrough bleeds. Incorporating ultrasound into routine follow-up enables earlier identification of subclinical synovitis and supports timely clinical decisions. The frequency of ultrasound assessment should be tailored to patients based on their age, breakthrough bleeds, pre-existing synovitis, and level of physical activity. Preventing bleeds through prophylaxis remains the most effective approach to promote long-term joint health. In case of identifying synovitis, action should be taken as early as possible because inflammation and hypertrophic synovia can be reversible at an early stage. Management should be multidisciplinary and may include reviewing and optimizing prophylaxis, anti-inflammatory medication and analgesics, physiotherapy to support joint function and movement, of course, patient education, and close imaging follow-up. The goal of treatment is to interrupt this cycle of bleeding, inflammation, synovitis before irreversible arthropathy develops. To summarize, bleeds, including subclinical bleeds, can occur despite patients receiving prophylaxis. Synovitis is the last reversible step in the cycle leading to arthropathy. Routine assessment of joint health is therefore essential and should include imaging such as ultrasound to facilitate the detection of early abnormalities. Patients with hemophilia A and synovitis should be treated as early as possible with intensified prophylaxis to improve hemostasis. Thank you very much for watching this video. I really hope that you found it useful. And you could find more detailed slides on this topic for download on the COR2ED website.